मैडम ने बोला था तो
I can't hear.
डॉक्टर
I'm outside. I'm just getting into the office. I will just speak to you there.
नो प्रॉब्लम let's start. Good evening friends. I am Shrenik, patient ambassador of Indian Cancer Society and the host of Fridays with Shrenik bi-weekly live webinars. And if I'm not mistaken, today is our 43rd live webinar. So far, we have invited more than 32 cancer specialists to our platform. And yes, we are always committed to talk about cancer awareness, prevention, treatment protocols, etc. And today we have a very esteemed uh,
Oh my
urologist,
God, Dr. Raj,
uro-oncologist,
we just started a live.
Dr. Ashwin
So
Malaya
after
from Sri Gangaram Medical Institute, Dadi. And apart from being uro-oncological surgeon, he is also performing robotic surgeries and got trained in US, UK, and India, and he has performed extensively quite large number of urinary tract and urological surgery in India. Dr. Arjun, over to you, and thank you so much for joining us despite your heavy commitment and rather rushing out from Operation Theater. So, thank you once again for joining us. Over to you.
Thank you, Shrenik ji, Jyotsna ma'am, everybody present here, and the people who are watching us on YouTube. Uh, Greetings from Sir Gangaram Hospital, New Delhi. So we are about 1,000-bedded hospital, and this hospital has been running the show in Central Delhi from the last approximately 70 years. So I feel esteemed. I feel it's my privilege to be working here in this institution, and it's a bigger privilege to be treating cancer patients. Yeah. And because cancer patients require a special kind of care, because it's not just care doesn't stop at diagnosis and surgery. These people become our lifelong patients. Okay, they'll even I'm a surgeon, I'm a neurosurgeon, but my patients who go through chemotherapy, immunotherapy, radiotherapy following the surgery. So there's a lot of back and forth. So we interact with them over several years, Okay, so that is why it takes a special kind of the doctor to be, a cancer doctor, oncologist. So I feel privileged to be a uro-oncologist, and I'm involved like Dr. Like how Shrenik ji mentioned. So my main area of interest is uro-oncology. I'm a trained urologist with fellowship training in robotic surgery. So today the talk is going to be very, very simple, because I understand that the people who are going to be watching this are people who might be having, the curiosity to learn more about cancer, who might be having relatives who suffer from this particular cancer, for example, urinary tract, like urinary bladder cancer or prostate cancer, or there might be students who, like medical students, or other students who are interested in this field of cancer. So it's first of all, I'd like to thank India Cancer Society and India Cancer Society branch of Delhi for giving me this opportunity. And I'm acquainted to this through my mother-in-law, Manju Sipaya ji. I see that she's also in the audience. So it's another proud moment for me, okay, to be talking here in her presence. Okay, and with that introduction, I would like to take the talk forward. So the talk today, I'll just share my screen. I hope you can see my screen now.
Yes, we can see.
Yes. Yes. So cancers related to the urinary tract, what one should be aware of. Okay, there are a plethora of cancers, but we cannot talk about every single cancer in the urinary tract, but at least I've tried to get a lot of general information which should be out there. And what I feel in my practice that I wish the patient knew before coming to me, because that is what awareness is all about. Awareness happens, the importance of awareness is known when the stage of the cancer is diagnosed. Aware patients get diagnosed in early stages. Those who are unaware at that point of time, at least, okay, might get diagnosed later. And that makes the difference. For example, just to give you a simple example, prostate cancer, if I find it in the first stage, okay, I can give a cure rate of about 95 to 100% over the next 5 years. We talk about overall survival in cancer parlance. Okay, whereas if they are in stage 4, when I find them, the likelihood of giving 5 year survival comes down to 35 to 40%. So that is why awareness is paramount. So that is why I feel very blessed that I'll be giving this talk on awareness about urinary tract cancers. So this is a beautiful photo of where I work. So this is Sir Gangaram Hospital in New Delhi. It's in central Delhi. And I'm a proud doctor associated with Sir Gangaram Hospital. So Shrenik ji has explained what I do, but as you can see, I'm working with the robotic systems. The latest that we have is called the Medtronic Hugo, and I'm also a teacher. I teach residents in urology. We get 4 residents per year through a rigorous selection of NEET super specialty exam. And I have trainees working with me, and I have other seniors and colleagues who work with me. And the blessings of Sir Gangaram, who's sitting behind me in the statue, you can see. And these are a few glimpses of my routine day, what I do daily. Okay. So first of all, let's come to a very simple idea. What is cancer? Cancer basically means that there is abnormal and disorderly growth of cells. Okay, it could be in one organ or organ system. So there's unregulated growth of cells, as in the normal regulatory mechanisms do not act. Okay, there could be an underlying mutation which the patient has, which he is born with. Okay, and there are environmental factors which combine together with the underlying mutation and lead to cancer formation. So these environmental factors, for example, could be smoking, exposure to pollution, obesity, okay, and there could be a lot of different risk factors, okay, and alcohol intake, for example, that also in some cancers is known. So that's why there was this very famous 2-hit hypothesis, wherein if a person is born with 1 hit already, when he gets the second hit, that's when his cells start developing into cancer. So this was a very famous theory called the Knutson's 2-hit theory, so which is a basis for a lot of cancers that we see. Okay. So I will be focusing on the urinary tract. So these are the organs I work with upon on a daily basis. So you can see that there are kidneys. We are born with 2 kidneys, and most of us are born with 2 kidneys. Rarely there could be a single kidney. Okay, and there are 2 ureters. So kidneys are involved in the formation of urine, which eliminates the waste of the body through filtration. Okay, and it's excreted into the urine. So the urine comes through these pipes called the ureter into the urinary bladder and comes out through the urethra. So there are some other organs which are associated with this in uro-oncology. That is the prostate gland, which is basically situated right beneath the bladder. Okay, and the function of it is primarily in the reproductive age group. It contributes to majority of the semen formation. The fluid that is there in the semen is contributed by the prostate gland. So urethra travels through this prostate gland, and then the other organs that we treat are the penis, the urethra, the pipe that brings out the urine, and the testicles. Okay. Apart from that, you can see there are 2 small glands above the kidneys, okay, which we basically know as the adrenal glands. So we treat cancers of these glands as well. So that is in short the anatomy, just for the lay of the land, so that you can orient yourself when you're thinking about these urinary tract cancers. Okay. And obviously, some of the organs are present only in men. For example, the testicles, they're present only in men. The penile area is present only in men. Prostate is also present only in men. Okay? So that is why my predominant patient population is elderly male. So I have a lot of expertise in counseling these people, and a very unique population, so I should say, because they have seen life, they have worked hard all their lives, they have retired, and most of them are retired. Some of them are still doing social service and doing some voluntary service. So it's a pleasure to learn from these people when they come to the OPD. So let's come to what symptoms you should watch out for when we are talking about urinary tract cancers. The first and foremost, what I want people to understand is that blood in urine, and it's usually a painless passage of blood in urine. It could be associated with clots in the urine. The urine could be clear. At the end, you may have some clots, or the whole urine may become pinkish in color or reddish in color. So, blood in urine is never normal. In medical parlance, this is known as hematuria, and that is never normal. Okay, it should never be ignored. We do have cases where blood in urine can be due to non-cancerous causes. For example, urinary stones or urinary infections or benign prostate enlargement. But still, it should be evaluated because many times we will find some, underlying cancerous growth in the, cancerous growth in the urinary tract. Apart from this, swelling in testicles, for example, a person who's developing a rapidly growing painless swelling in the testicles, that is another cause for concern, that this is a symptom that should be checked by the doctor. There could be a lump in the flank region of the abdomen or in the upper abdomen or sometimes even in the lower abdomen. So any lumps, abnormal lumps or heaviness you're feeling, that should be examined. Some patients come with the complaint of blood in semen. Okay, it's not always a cause for concern. It could be just an infection, but prostate cancer is also known to cause this, blood in semen. Sometimes there are people who don't, they are unable to retract the foreskin of the penis along with the bloody discharge or a lump felt in the penis. So that again needs to be checked out by a urologist. So, these are the symptoms, that should, alert the patient, alert the person that these are the symptoms. We should take the specialist opinion and find out what we are dealing with. Okay, then there are some generalized symptoms. Those were some of the specific symptoms that I mentioned before. Now there are some generalized symptoms, as we know: weight loss or loss of appetite, unintentional weight loss. Weight has always been 75, but you've not changed your diet, not been doing some special exercising or something, suddenly has dropped to 70, 68. So cause for concern, maybe something else, but should be should be evaluated. Are we having some underlying malignancy? Okay. Difficulty in urination. So this again can be due to age-related benign enlargement of prostate or may exist with prostate cancer as well. So this needs to be checked out. Unexplained fever continuing for a long period of time. So, okay, you have fever 3 to 5 days, viral fever, 7 to 14 days, typhoid fever, or recovering from dengue fever. But fever that goes on for many weeks could be tuberculosis. But sometimes we have diagnosed people with fever for prolonged periods of time, and we find out they have an underlying malignancy, like even a blood cancer, or sometimes rarely a kidney cancer. So, kidney cancer is special in that it has something called paraneoplastic syndromes, where it mimics a lot of other disease processes. So, they can present only with fever. And when we get an ultrasound done and we find out there's a kidney mass. Generalized bony pains. So bony pains can be there with age. A lot of people develop arthritis, and this is always considered. But a person who develops a severe bony pain at one or two locations, or may develop a fracture with a very trivial trauma. Okay, it means that there is some underlying bone destruction there, and that may be the symptom of underlying prostate cancer which has metastasized to the bones. Okay, so we do see this situation sometimes. So these are some of the generalized symptoms that I've talked about, just to keep in mind for awareness. So how we as doctors are picking up on these patients? So when a patient comes to me, generally, So what are the complaints? They sit in front of me and they tell me, Anji, aapko kya takleef hai? So these are the usual things they come for. Okay. These are my typical OPD patients. Okay. So they say that they have blood in urine. Okay. Then I have to think whether they may be having a urinary bladder mass or any upper tract, the ureteric mass or a kidney cancer. Could it be that? Just we don't blurt it out openly, but we do have that going on in our mind that this is something that we may be considering. Elevated PSA. So, what is PSA? PSA is a simple blood test which is done in your close by any neighborhood laboratory. Okay, it is prostate specific, it is not prostate cancer specific, and it may indicate that there may be an underlying prostate cancer, but it has to be interpreted by a urologist. Okay, it is even my general physician friends, I tell them, please try not to interpret PSA on your own because there are too many nuances. Okay, there are a lot of factors that may increase PSA. There could be any benign enlargement of prostate will elevate it a little bit, any ongoing urinary tract infections, any prostate examination that was done recently, any infections that are going on, that also may elevate PSA. Prostate cancer may also elevate PSA. So please see a urologist for evaluating an elevated PSA. Nobody else. Ultrasound abdomen as a part of general health check. So a lot of patients nowadays who are working in corporate in Gurgaon, Noida, they come to us and they say they had a routine health check and that time they found a mass. There was a kidney mass or an adrenal mass or a bladder mass and they didn't have any other symptoms. But okay, your health check saved you from a lot of heartburn later. Okay, and we are able to treat it early. And sometimes people come that I was just examining myself. I found that I found a lump in the testicle or I found this penile lesion. Could you please check it out? So these are all the things that we look for when we are picking up on these patients. Okay. So knowledge is power. And I've told you why early detection is necessary. So just some general tips. Okay. Yearly PSA test, I do recommend for everybody who is at least above the age of 55. But earlier, if there is a strong family history, okay, there are two people in the family, uncle, brother who had prostate cancer at the age of 50, 55. In them, I suggest that please start screening at the age of 45 or 50. But 55 onwards is a good measure that at least yearly, if you get a PSA test done, we may pick up early on prostate cancer. This is another thing that I say. I might be criticized for this. Ultrasound of the abdomen once every 2 years from the age of 40. Why I say this is we do pick up masses in the kidney early and we can save the kidney. We'll just remove the lump from the kidney by doing a beautiful surgery called partial nephrectomy. But if this mass were to be bigger, okay, we'll end up removing the whole kidney when it is detected years later due to symptoms. So once you're 40, every 2 years, try to get an ultrasound whole abdomen. Many of you working in corporate, the office gets it done. But even if you are investing in this once every 2 years, it is very useful. Never, never, never neglect blood in urine. Okay. If it's happening 1 day, 2 days, a week, don't wait. Just see a urologist. Just like how breast cancer has done a lot of detection based on breast self examination. I'm sure you've heard of that. Similarly, I recommend that testicular self examination starting from the teenage itself. Okay, there's a method in which it has to be done. We recommend that at least once a month you do a systematic examination of the testicles, and even the penile health is necessary. A lot of people are very shy to talk about this, but I feel this has saved a lot of people from cancerous growths. And when they have been found, they have been detected early. Okay. So again, what are the risk factors? Somebody might say, okay, doctor, why did I develop this? Why did I develop this prostate cancer or kidney cancer or urinary bladder cancer? So family history is important in cases like prostate cancer because there are some genetic mutations that may predispose them. For example, BRCA2. Okay, we find it in ovarian cancer also and in prostate cancer also. So there might be some family history that some familial cancer history is there. So in them we have to watch out. That might be a risk factor. genetic mutations because of exposure to toxins in the body. We don't know the food that we are eating, the water that we are drinking, what is there in the water supply and food supply. A lot of facts are coming out now. Recently, there was an article that there is so much heavy metal traces in the water supply. So we really don't know what we have put RO at home, but we don't know what we are drinking, the water supply. So, the cancer incidence is increasing year by year across India. So I don't know if this is a price of development or what it is, but we are being exposed to the environmental pollution. Lifestyle factors: people who are obese, people who have uncontrolled blood pressure, lack of exercise, very sedentary lifestyle, smoking and tobacco, uncontrolled diabetics. All these people are predisposed to cancer. Okay. So why I say that, you should at least try your best to maintain a normal weight, have a healthy diet, try to control your blood pressure, meet a doctor. So it's sometimes it becomes very difficult when you are very busy and you don't have the time to visit a doctor or somebody. But please make time for your health. Some infections like human papilloma virus. I'm sure you've heard of HPV vaccine. Nowadays, it's coming up it's becoming very popular. Gynecologists are suggesting that all girls should get it from the age of 12, 13, 14. So a human papilloma virus is a predisposing factor for penile cancer. Okay. So contamination of food and water, like I told, artificial dyes, heavy metals, we don't know what is there in our supply. So once we have such patients, we proceed with a detailed history and physical examination. We get our blood and urine investigations, ultrasound, CT, MRI, and PET scans. About biopsy, when to do and when to avoid, let the doctor decide. Okay, this is becoming a very, very big point of concern for me when I'm sitting in the OPDs. A patient comes, and many times when I advise a biopsy, for example, a prostate biopsy, the first question that they ask is, "But doctor, we have heard that after doing biopsy, the cancer will spread." So that is exactly when I tell them. So is this what you heard from your local neighborhood park uncles when you were talking or when you discuss about how the country should be and how everything? So I know senior citizens do form very good groups. It's very important to socialize, and but at the same time, I feel misinformation should not be there. So biopsy or not to biopsy, please don't decide yourself. Please meet your specialist doctor and let the doctor decide. Then we do something called cystoscopy, where we put a camera through your urethra into the urinary bladder. It helps us pick any bladder cancers. Okay. So these are the usual things that we do. And we always have multidisciplinary involvement. So suppose I have made a diagnosis of prostate cancer, which has spread to the body. I will involve the medical oncologist, maybe for chemotherapy, maybe for second line agents, radiation oncologist, whether there is any role of radiation, nuclear medicine specialist. So we have a tumor board every week. So most institutions who are treating cancer, they have a tumor board. We sit and deliberate and debate. So there are a lot of healthy arguments so that a patient is at the center of all this, so that the patient gets the best treatment. Uh, we always try to find whether the disease is confined to that particular organ or has it spread to other areas. Is it stage 4? Is it stage 3? Is it stage 2? Surgeries are most often used curative option in urinary tract cancers. For example, there is a kidney mass, we may remove the kidney or part of the kidney. There is a prostate cancer, we will remove the prostate. Radiation is an alternative curative option in some cases, like prostate cancer, but not in every case. It's case by case. There is chemotherapy available and immunotherapy. That is the new kid on the block when the disease has generally spread or is advanced. So now we have made a lot of advances. We have full body imaging PET scans, which help us pick up metastatic disease, stage 4 disease, very high tech MRI and CT scans, which will pick up small prostate lesions. Robotic surgery and minimally invasive surgery with small or no cuts in the body causes early recovery, and we are able to do precision surgery. We have very precise radiation therapy. Earlier, there used to be a lot of collateral damage when radiation was being delivered. So, suppose they're irradiating the prostate, even the bladder would get some radiation, the rectum would get some radiation. So, there would be problems associated with that. And immunotherapy has been a game changer in stage 4 disease. Many times we are able to give a good overall survival with immunotherapy, although very expensive at present. but definitely it's something we are all excited about. So just to show you a small video, okay, now this is a small video clip of a robotic prostate removal that I'm performing. Uh, this I'm dividing the prostate from the urethra. So the robotic surgery gives us 10 times magnification, immersive technology. It seems as though you're sitting inside the body and operating. And this I'm seeing on my 3D console. All this I'm seeing in 3D vision. So this I'm stitching the bladder to the urethra. You can see with the ease with which I'm able to perform this surgery. So several years back, this used to be so difficult to perform this connection between the bladder and urethra. I just wanted to give you a inside view what we do on a daily basis. I felt that you people should have some exposure to this. So uh, so coming to the last slide, I had, I always like to give take home messages because in case you have been sleeping the last uh, 10, 20 minutes, at least you can see this one slide and, take home some messages and maybe discuss and deliberate among your family members and friends. So, sir, awareness is key. Knowledge is power. So the awareness is there. You should not. You should not be scared of being aware. Although there's a lot of nuances, a lot of हम हिंदी में जैसे बोलते हैं इसमें बहुत बारीकियां हैं. Okay, but being broadly aware is useful. Okay, it's useful, and knowledge is power. Okay, general physicians. So when you have your local family physician or general physician, they should have a high index of suspicion. Sometimes I'm unfortunate, sometimes what happens, general physician is very busy. He may not pick on small signs and small symptoms that the patient may be giving. So I request my general physician colleagues to have a high index of suspicion because the patients will come to you first. So they don't come to us. And when you go to a specialist doctor, you'll get very specific information. Okay, second opinions are always welcome. Suppose you're not satisfied with the diagnosis or something, take a second opinion. There is no harm. So even when I feel that I am hitting a dead end in my diagnostic modalities or treatment modalities, I even suggest my patients that you take a second opinion. Let us see, because patients need the best. Okay, we cannot decide everything for them. So if we are, let us be honest enough, and second opinions are always welcome. And don't neglect symptoms like blood in urine, unexplained weight loss, prolonged fever, lumps in the testicle or lumps in the penis. And the PSA test, since it's part of the health executive health check package in most labs, like you go to a lab nowadays, nobody will do 2 or 3 tests. They'll say और 500 रुपया दे दो और 1000 रुपया दे दो आपके 36 टेस्ट हो जाएंगे. So because of that, the PSA test is done many times, and then the PSA is beyond range and the patient panics, and then there's a lot of this. So always the PSA test should be interpreted by the urologist. So that's it, Shrenik ji and Jyotsna ji. I thought, yes, I was told 25 to 30 minutes that I made it in time.
Thank you. Thank you, Dr. Ashwin. There is one question from the audience, like, what is the preferred treatment protocol, whether robotic surgery or the manual surgery? If you would like to answer, then, I have some other questions that I'm going to ask, but, I would like you to answer this first.
Yeah, so whoever has asked that question, thank you for that question. So, see, what is robotic surgery? It's not like a robot is, taken over my job. It's not like, uh, so one day I'll tell you a funny incident. A patient came to me and said, डॉक्टर साहब देख लेना, अगर आप ही कर सकते हो, रोबोट वोबोट तो आते जाएंगे, बट आप कोशिश करना कि आप ही करना. So robot is not something that has replaced us. Robot is something that the technology, it's like laparoscopic surgery. I know that laparoscopic surgery is popular, that we make small keyhole incisions and we pass these ports, and through them we put the instruments and the camera and we operate. So earlier laparoscopy we were doing with the hands only. So that is manual. Manus means hands in Latin, if I'm not mistaken. So when we say manual, we are doing with our own hands. So the older surgery was we used to make very big incisions, and with our own hands, with the instruments like scissors and artery forceps, we would dissect and remove the tumor. Then we went to the era of laparoscopic surgery, when we made keyhole incisions and did precision surgery. But the problem was, it requires a lot of skill and a lot of dedication to become excellent laparoscopic surgeons. So what the robot did was decrease the learning curve for the surgeons to master minimal access surgery. We can provide 10x magnification with robotic technology, and there is absolutely no tremor. It's absolutely fine movements. When I'm doing a prostate cancer surgery, I'm deep in the pelvis. It's a very difficult to reach area of the body. When I'm doing this surgery, the most difficult steps with the laparoscopy have become the easiest steps now in robotic surgery. So for prostate cancer, robotic surgery is the gold standard. For partial removal of the kidney, robotic surgery is the gold standard. For complete removal of the kidney, we still depend on laparoscopy, but robotic surgery is slowly making inroads for that as well. So case by case basis, robotic surgery is replacing laparoscopic surgery in many areas.
Thank you. Chandraji, if you would like to ask question else, I will ask him.
Dr. Malia, firstly, I want to thank your mother-in-law for pushing you into coming and talking to us.
It's my
It's
pleasure.
been,
It's my
it's
pleasure.
been a very valuable talk, and with your permission, we would like to use it in our app and in other information material.
Absolutely. There is no need to ask. I was made aware by Shrenik ji. He has been communicating with me that this will be put on the YouTube channel also.
Yeah.
And my purpose is that I should reach as many people as possible. And I think this is something, if we have the knowledge, it should go to the people.
No, I need to ask because when we put it on our app, it will be edited to take out all these pretty conversations on the side.
No problem. No problem.
Okay.
No
Now,
problem.
my question is how much awareness work among men is actually done? My experience is that men are far more coy about their private parts than women are. Women will speak openly about a breast lump. They will go and see somebody and ask a doctor's opinion. When we teach them to do a self examination, they do it and they check out that what they're doing is correct. But when we talk to men about a testicular self examination, very few of them are actually looking to see what is being demonstrated.
That's true.
So, how do we get over this coyness? Because I really feel that more men would come in early stages of disease if they did just that. You too have spoken about the prostate. I suppose that's part of your urinary tract
Yes, ma'am.
field, but surely so are the testes. And it's the young men with their very tight jeans, with their thundering motorbikes. These are all prime candidates for testicular cancer.
Absolutely, ma'am. You are very right. And it's a great observation that you have made. And you're absolutely spot on. I'll tell you why. Because so the month of November that just passed by, okay, it's called the Men's Health Month now. We call it the Movember month. So why
Yes.
the Movember came into being? Let me just digress a little bit and tell you. Yeah, exactly. So she's pointing out. So the Movember movement started in the United States. So the incidence of prostate cancer. So it was found, even as per research, that men were less likely to talk about their problems because they're expected in the eyes of society to be very stoic, should not be complaining, should not be talking about their illnesses. Okay, they don't like to listen to their female partner as well, probably, but men were just not talking about it. And they were presenting late, they were presenting in stage 4 in many cases. So and they were also not at all talking about their mental health. Okay, For example, something is affecting them, and this led to higher rates of suicides among men than women. So this Movember movement marked by, so how this Movember movement they follow it, people start growing mustaches in the month of November. So that kind of incites that conversation. Okay, somebody would be like, why are you growing a mustache? Okay, are you not aware that this is November? This is mustache November. So what is this Movember movement? So this movement is about men's health. This movement is about prostate cancer, testicular cancer, male mental health. Oh, what is testicular cancer? How does it happen? So that conversation is incited. Okay. So just for that was such a game changer. Movember movement caught on so well that there were marathons organized, there were prostate cancer survivors, there were prostate cancer foundations taking part. So more and more awareness came through. Okay, so this is very right. The young people also, like how breast self-examination is being taught to women as part of the comprehensive health checks and everything. Testicular, checks should be advised to young males. Okay, once they reach, because I have patients who have come in with, when we could have done something, avoided chemotherapy, for example, if they had presented in the early stage. So we have such patients, people who are in 11th standard, 12th standard, appearing for board exams. So, and they had this and they were very shy to talk about it. They were very busy with board exams, they were busy with sports, and they kind of didn't talk about it to their parents. So it's very important, ma'am. And as far as how do we get men to be less coy, so I think it's a personality trait. I think we can't change thousands and thousands of years of evolution. But I think one thing is true that just this simple conversation, like this Movember movement, it's like people come to know, oh, many people haven't heard of what is prostate.
Yeah.
People think it is, people think it is something that is like women think they have a prostate. Okay, so women don't have a prostate. So men don't even know about the prostate. So definitely, when it first happens to them, and I tell them that this is prostate cancer. So I have to start from what is prostate. Okay,
Can
so
you also add, please, is the prostate a separate organ or is it a gland?
yeah, it's counted as an organ, okay, but most of it is glandular. It has got other parts of it, other parts to it as well, but most of it is glandular. The most important function of it, like I said, it contributes to the semen production. So
Yeah.
70% of the semen is the prostatic fluid secretion. So it is a glandular organ, and in the reproductive age group, it's functioning well. And as they age, it starts growing in size sometimes or causing problems in the urination, and sometimes it develops into cancer. So many people think that prostate enlargement is synonymous with cancer. That is also not true. So prostate cancer has a different pathway, and benign prostatic enlargement with age has a different pathway. So they are not to be confused.
Thank you.
Well, uh, Dr. Ashwin, before I ask question, I want to align something with Dr. what Dr. Joseph ma'am just asked you,
Nick, but
and
now you have must be knowing I'm not a doctor.
yes, I know. I said Joseph ma'am. So what I'm trying to tell you is that first of all, you know, as I said, we have done more than 42 live webinars, and this is for the very first time we are, live streaming something related with the urological or uro-oncological but segment, and to what she asked and what you have so remarkably explained, about the. So we are live streaming, and the best what we are really doing is that this is on this being live stream on YouTube, and we keep on promoting this on our various social platform already, so that more and more people, not in India but throughout the world, people will come to know what exactly. it means about prostate cancer and other types of urological cancer. So we are doing our best at the Indian Cancer Society Delhi. Now coming to Mike, I a very typical question, and that is rather related with the patient and their family members. I would like to understand the uh, discussion protocol within tumor board. Like there could be five, six, seven specialists discussing this particular case to case subject, case to case disease. Now, how do you take collective opinion? For example, if for example out of five or six or seven specialists, three will agree and three may not agree. So how do you take the collective decision in the best interest of the patient?
So, very, very, very good question, Shrenik ji. This is a beautiful question. Uh, you know, uh, so there are some institutions where every patient goes through tumor board, every single patient, whether it's simple, difficult, everything. So it's always a collective opinion. In some institutions like ours, it depends on who has brought the patient to the tumor board. Okay, most cases it's open and shut. Like it's like this requires organ confined prostate cancer. This requires and organ confined prostate cancer. This requires robotic surgery. Uh, we may say that you may take a radiation opinion as well, but this doesn't require really a tumor board. The cases that go to tumor board in our institutions are cases where definitely are very, very difficult to manage with one treatment modality. For example, advanced cancers. It has gone beyond the bladder. Okay, there are lymph nodes involved. Okay, should we give chemotherapy or immunotherapy first and then go to surgery? What are the pros of doing that? What are the cons of doing that? Let's all sit and brainstorm. He may have underlying kidney dysfunction, he may have underlying heart disease. So should we put, and the age may be advanced, so we consider all of that. So our tumor board gives a collective opinion, okay, at the end of it, that yes, I think we should go ahead. Finally we decide, it is documented that the tumor board advises that it's best to go in for chemotherapy first and then come in for surgery, and that is conveyed to the patient. Okay, and generally even if there is uh, some dissent, it is not like, it's not like parliament here. it's not it's not like parliament that somebody walks out and everything, but everybody is there for the sake of the patient. Ultimately, there is nothing personal about it. We have to be dispassionate and look at it objectively, and then we convey to the patient that the tumor board feels. Some many times I say that I have decided that I want to operate, but then I say I'll put it through the tumor board. And I have gone back and told the patient, see, tumor board feels that chemotherapy should be given first, or chemotherapy should be given later, or whatever. Okay, so I go back and say, this is what the tumor board has decided. Ultimately, patient is finally decides. Okay, they say, no, we are not in agreement with the tumor board. We want to go in, but it's a sanctity that is maintained at the end of the day.
Thank you so much. Anyone else would like to ask question to Dr. Ashwin sir? Please unmute and you can ask question. Doctor has to go early, so we would like to, finish the session at the earliest. But yes, he's always there to answer
You- Excuse
any
me?
questions.
Yeah, I would like to ask one
Please.
question. Uh, what is the role of hormones in cancer?
I mean, cancer in general or any particular cancer?
Normal cancer.
Ma'am,
They're
cancer is
all
not normal.
normal, right?
Okay. I mean, I understand. I
I,
think
yeah,
you're basically
I would like to I would like to say normal means in any part of the body.
any part of the body. Okay. Thank
Yes.
you. Thank you for that. So there are some cancers that are hormone dependent. Okay. For example, prostate cancer, okay, is
Okay.
dependent on testosterone. Breast cancer, uterine cancer. Okay, some of these are hormone dependent tumors. So when I say hormone dependent, it doesn't mean now suddenly some of you might be thinking, oh my God, I got my testosterone levels done and it was my doctor told me it's very good. So does that put me at risk for prostate cancer? So that's not true. So there are some mutations in the body, okay, which cause cancer. But once this cancer develops, for example, prostate cancer, when it has spread to the other parts of the body, we start something called androgen deprivation. We give injections to suppress the testosterone levels. Because if we don't do that, the prostate cancer that has already spread to the rest of the body is going to further increase. So we cut off the main feeding hormone, that's testosterone. So hormone levels and cancers don't have correlation in healthy individuals. But once cancer develops in some cases, like prostate cancer, especially in stage 4, we have to give medications to suppress the hormone. Okay? So that's called hormone therapy in general parlance or androgen deprivation therapy when we talk in medical field. So in healthy individuals, hormones are not any cause for cancer. So I just wanted to put it out there.
Thank you.
Yeah.
I have a strange kind of a question. I'm told by many people that with the corporate screening programs,
Mm-hmm.
young people generally say, we want to know about a treatment where the doctor does not put his hands on us. Now, I belong to a generation where the doctor did put his or her hands on a body and made a diagnosis partially on that. I'm not saying wholly.
True.
But how good or bad is total dependence on equipment like an MRI? Or everyone is asking for MRIs at the drop of a hat and they're getting it.
Hmm. I understand where your question is coming from. I totally agree with you. So, medical science is becoming more and more investigation dependent. Okay. So, by if the patient is psychologically rewarded by us examining them, then I'm all for it. But I cannot avoid doing investigations if needed.
Hmm.
Because today, in this day and age, uh, this is available. This is has already been established. For example, prostate examination. You know, I am all for it. Examining the prostate gives me so much information. It is a slightly uncomfortable examination. Okay, where we do a rectal examination to feel for the prostate. So men just despise it. Okay, when men hit 60, it was part of the protocol that prostate has to be examined by a urologist. Gradually, it is being given up in the United Kingdom, for example. But I still feel it gives me a lot of information, not just the MRI. Okay,
Hmm.
I can tell a lot of things about the prostate disease by examining the prostate. We have believers and non-believers. So medical world is divided into two. So I am a believer that physical examination necessary. Even if I have MRIs and PET scans in front of me. Many times, patient feels that in a hurry, I should not waste the doctor's time. Let me just shove that investigation into his face so that he can see 10 other patients. Sometimes they feel. Then I tell them, see, relax. I'll see all your investigations. First, tell me in your own words what's wrong with you, and then I examine, and then I see the investigations. So that systematic protocol is how I have been trained. So because it gives us a lot of information apart from the scans, it builds rapport with the patient. Okay, they trust you better, they trust you more. Okay, and I feel there are fine points that I can pick. Sometimes investigations may be wrong, and I have picked it up. ओके, राइट का लेफ्ट हो जाता है, लेफ्ट का राइट हो जाता है. So we have seen it all the time. So one additional layer of safety for me, as well as establishing rapport with the patient, I always examine the patient, even if I know that I may not find anything. Okay, but spending those extra 3-4 minutes with the patient, I think we owe them that much.
Thank you.
Dr. Malia,
Hmm.
I had a query. How is
Yes.
the quality of life of patients suffering from urogenital cancers?
It's actually not very bad. I'll tell you why. So we have cancers that are that can be detected early. So when we detect early, we can give curative option. When we cure, the quality of life is good. The surgeries that we do for it can be done using minimal access surgery. So getting back to their routine work, and the pain scores are less. Uh, very Some of them will go to chemotherapy or hormone. I mean, or any immunotherapy. So immunotherapy is also being tolerated very well, as studies have shown. So overall, I think, except probably in urinary bladder cancer, where
Mm.
we have to sometimes remove the bladder and make an alternative pathway for the urine to be coming out through what is called ileostomy. Uh, that also people get used to, and it can be managed very well with the help of our stoma nurses and stoma clinic. Okay, so overall, I think quality of life in urogenital cancers is not bad at all. Penile cancers, there is some morbidity, but more or less, most often when detected early, we can give curative options and we can avoid chemo. And the quality of life is a very broad topic, because it could be due to surgical morbidity, it could be due to morbidity due to radiation therapy, it could be due to chemotherapy or immunotherapy. So, and urogenital tract cancers are a very broad topic as such. So, case by case, I think if we see, urogenital cancers have a decently good quality of life.
Thank you.
I think we've gone 10 minutes over time for the doctor.
Yeah, exactly. So I think if there is no further question, let's allow Dr. Rizvi to go ahead with his opinion, surgery procedures, etc.
Yeah. So, I still have one more case to be done for the
Well,
day, and
uh,
some of my OPD is remaining, so I have to
uh,
finish that.
absolutely, absolutely. So, Dr. Ashamalia, thank you so very much for your valuable time, sharing your knowledge, experience, expertise. And as I said earlier, this is the first time what we have rather live streamed today's session pertaining to this urological cancer. And I would not, had I been in Delhi, I would have certainly come and see you and offer you coffee. So thank you so very much. And we would like to have you once again over a period of time. Thank you so very much. Thank you all attendees. Jyotaji, Priya Parmar, Manjuji, Namaskar. Thank you for joining. And Thomas, thank you,
Thank
thank
you, thank you,
you,
sir. Thank you.
thank you everyone.
Very well conducted session.
And
We
see
really
you
loved it.
in the two
Thank you.
weeks from now.
Thank you,
Thank you.
sir.
Thank you.
It was my pleasure, and
Thank you.
I
Bye bye.
look forward to
Thank you.
any,
Thank you, Doctor.
yeah, any activities of the Cancer Society. I would be happy to be a part of. And we have a very good department here, and we have a wide range of doctors across specialities. So we would be more than happy to collaborate for any
Thank you,
future.
Dr. Malia. Thank you so much.
That's great.
Thank you
Thank
so much.
Thank
Thank
you.
you.
Bye.
Thank
Bye
you.
bye.
Thank you, Doctor Arjun. And next time I will be in Delhi. I would love to see you in person.
Okay, thank you very much. Surely. So you are a big inspiration. So we just love seeing your posts on LinkedIn.